Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. The term amyloidosis is equivalent to a descriptor of a collection of diseases. Think about the term cancer. It describes a collection of diseases such as breast, lung, prostate, etc. All dramatically different diseases, and it's absolutely critical you know what type of cancer you have in order to develop an appropriate treatment plan. The same applies to amyloidosis. Once someone is diagnosed with amyloidosis, the second part of the diagnostic process is to identify the type. For example, AL, light chain, or ATTR, the transthyretin type. And then for ATTR, it's necessary to go even one step further to identify the subtype, such as wild type or hereditary. So in this episode, we'll hear from Dr. Mazen Hanna, a cardiologist at the Cleveland Clinic and co-director of the amyloid program. Adapted from his video, Cardiac Amyloidosis, AL, and ATTR, two different conditions, he explains how cardiac amyloidosis can originate from two very different types of amyloidosis. Dr. Hanna illustrates how clinicians can identify cardiac amyloidosis and look to different diagnostic workups to understand whether the issues are due to the AL or ATTR form. These two conditions are treated uniquely and have different prognoses, emphasizing the importance of identifying the type of amyloidosis involved.
Morning, my name is Mazen Hanna from the Cleveland Clinic, and I'm going to be discussing cardiac amyloidosis, the two main types, AL amyloidosis and ATTR amyloidosis, and how these two conditions differ. Just to review, amyloidosis is a protein misfolding disorder. Normally, our proteins are in a three-dimensional folded shape, and due to various issues, they can pathologically misfold into more linear structures that then accumulate and aggregate into these rigid and non-branching amyloid fibrils you see there on the right, which deposit in tissues and organs, causing dysfunction. And under our electron microscopy, they look indistinguishable regardless of the protein that leads to the amyloid fibril. And what they all have in common is when you stain with Congo red and you visualize under polarized microscopy, you get this apple green birefringent pattern diagnostic of amyloidosis. Now, there's two main types of amyloid that affect the heart. The first is AL, or light chain amyloidosis. In this case, this is a plasma cell bone marrow disorder in which the precursor protein that's misfolding is a light chain, which is part of an antibody. And then the other more common main type is called ATTR, or transthyretin amyloidosis. In this case, the liver-derived protein transthyretin is what is the precursor protein for forming the amyloid fibril. And in either case, you get deposition in between the muscle cells, stiffening and causing dysfunctioning of the heart. Now, on the very lower left, you see these other very rare types of cardiac amyloidosis. But by and large, when we talk about cardiac amyloidosis, we're really referring to AL and ATTR. Now, the pathology of amyloid heart disease is typically diffuse. So you get deposition of these rigid fibrils in the left ventricle and the right ventricle, in both atria and in the intraatrial septum. The mitral and tricuspid valves can have deposition. The conduction system, which runs through the muscle, can be affected. And in certain conditions and situations, you can have deposition in the very small coronary arteries, causing ischemia. This is a normal autopsy heart on the left, and you can see a very severe example of cardiac amyloidosis on the right. This person happened to have TTR amyloidosis, and you can see the left ventricle is massively infiltrated. The right ventricle and the atria are really, really big. And again, you cannot tell the difference on an echo or even an autopsy specimen of whether it's ATTR or AL. They're two very different diseases, as I will be about to explain to you. And just note, when we do a heart biopsy to determine if someone has cardiac amyloidosis, while we see indirect evidence on H&E stain, which is this pink stuff, which is the amyloid surrounding the red, which is the muscle cells, and sometimes it can be more subtle, ultimately, the pathologist has to tell us if it's AL or TTR using either immunohistochemistry or mass spectrometry, because the prognosis is different, the treatment is different, and further testing is different. So it's crucial to distinguish between these two types. These patients can present with cardiac symptoms and non-cardiac symptoms. Heart failure, they can be misdiagnosed as hypertrophic cardiomyopathy, which is another genetic condition that can cause the thickened heart. They can have low flow, low gradient aortic stenosis, particularly in older patients. Their first presentation can be atrial fibrillation or even a cardioembolic stroke. Some patients can have a heart block and need a pacemaker, and others can have angina or cardiogenic shock due to the deposition in the small coronary arteries. But it's these non-cardiac clues that can be very helpful. So symptoms of neuropathy, either autonomic neuropathy, such as orthostatic hypotension, diarrhea, erectile dysfunction, or peripheral neuropathy. Proteinuria and/or nephrotic syndrome is classically seen in AL amyloidosis, and macroglossia and paraorbital purpura is almost always going to be AL amyloidosis. Whereas bilateral carpal tunnel syndrome, spinal stenosis, and biceps tendon rupture are mostly, if not exclusively, found in TTR. So AL amyloidosis is a rare condition, about 5,000 to 7,000 new cases annually in the United States. As we stated, it's a plasma cell disorder like a cancer. Median age of diagnosis is 63. And historically, if someone had AL amyloidosis and presented with heart failure, they had a dismal prognosis. And it's important to note this is a multi-system disease. Again, here you can see a picture of the plasma cell producing the antibodies, and the light chains themselves are what forming the amyloid fibril. The two most common organs affected are the heart and the kidneys. And in the kidneys, it typically causes glomerular damage and proteinuria. But you can also get liver dysfunction, neuropathy, GI symptoms. And on exam, you can have, as we discussed, macroglossia, which is an enlarged tongue due to direct infiltration, and paraorbital purpura, which is basically bruising around the eyes, which is related to fragility of the capillaries. Another couple symptoms that you get in AL is hoarseness and jaw claudication. Now, just a primer on plasma cells. Normal plasma cells constitute 1% to 2% of our bone marrow, and they make intact immunoglobulins or antibodies, which are comprised of 2 light chains and 2 heavy chains. If you have a clone of plasma cells, our plasma cells either produce kappa or lambda at birth. So your plasma cell is born either as a kappa type of light chain producing or a lambda production. And if you have a clone, let's say of abnormal lambda, you're going to see more lambda light chains in the serum than kappa. So if you have a plasma clone, one of 3 things can happen. Either that clone is not very large, and the light chain that it produces does not misfold and cause amyloid. That's called MGUS, or monoclonal gammopathy of undetermined significance. Another outcome of a plasma clone is that it's very aggressive, and it can cause hypercalcemia, renal insufficiency, anemia, and bone lytic lesions. And these light chains tend to be high, but they do not misfold and form amyloid. That's called multiple myeloma. And the third potential outcome is the clone can be of any size, but the light chains themselves are prone to misfolding and forming amyloid fibrils, as you recall that very first slide, and that's amyloidosis. Now, shifting gears to TTR, which is a completely different condition. In this case, the precursor protein is made by hepatocytes in the liver, and the way it's secreted onto the blood, it's secreted as a tetramer. Tetra is 4 for Latin, and each monomer is 127 amino acids each, and they come together at this dimer-dimer interface. And what happens is there's tetramer dissociation. This can then break down into the individual folded monomers, which misfold, and they ultimately lead into amyloid that In this condition, classically deposited in the heart and or the nerves and the soft tissues and ligaments. There's two subtypes of ATTR amyloidosis. One is wild type. There's no mutation in the TTR gene. It is not hereditary. It is a disease of aging. We do not know why at a certain age in some people that tetramer falls apart and dissociates into monomers, but the median age of diagnosis is 74 years, and it's much more common than we thought. About 25% of patients over the age of 80 have wild type deposits on autopsy. Now, the variant, what we used to call mutant, there is a single amino acid substitute mutation in the TTR gene. It's hereditary and autosomal dominant inheritance. And the age at presentation and the organs affected depends on the very specific variant. There's been over 100 variants described. The most common one we'll describe is this one in African Americans called Val 122 isoleucine that causes a late onset cardiac amyloid. What they both have in common is orthopedic and ligamentous issues. And the only way to distinguish wild type from variant is genetic testing of the TTR gene, which is a simple blood or saliva test. Again, carpal tunnel, often bilateral, spinal stenosis, biceps tendon rupture, and even shoulder or pathology of rotator cuff tear are not uncommon, and they often happen before the cardiac manifestations of TTR. And this is just an example of carpal tunnel soft tissue that can stain positive for amyloid, and the carpal tunnel will often be symptomatic maybe many years before the cardiac. And this is an example of spinal stenosis, and biceps tendon rupture occurs in 10 to 30% of patients with wild type, and oftentimes they'll have this Popeye arm due to a previous biceps tendon rupture. If you look at the 100 to 150 variants in hereditary ATTR or variant ATTR, there are some variants that cause mainly cardiac disease, some that are more neurologic or neuropathy, but most of them are mixed, causing both. The most common one in the United States is this variant called Valine 122 isoleucine. It's heterozygote carriers, 3.5% of African Americans, so they can put them at risk of late cardiac amyloidosis. And then the second most common is this threonine 60 alanine variant, which is found in patients of Irish descent, and they classically present with carpal tunnel first, and they can present with both cardiomyopathy, significant degrees of heart block, and neuropathy. The mutation that you have or the variant will depend on what age. So the V122I African American variant, you can see in this line, average age is in the high 60s, whereas the Irish variant, the average age is in the high 50s or early 60s. And then there is a variant in Denmark that penetrates as early as in the 30s and 40s. So every variant tends to behave differently. And by echocardiogram, what you're looking for is thickening of the heart as the clue. And the differential diagnosis, of course, is hypertensive heart disease, hypertrophic cardiomyopathy, aortic stenosis, or many other conditions. But amyloid heart disease should be within your list of differential diagnoses. Just to end with a couple cases, this is a 55-year-old white male who presented with nephrotic range proteinuria and heart failure. Here you can see what's called an apical four-chamber echo view, where you have the left ventricle, the right ventricle, the left atrium, and the right atrium. And you can see both the left ventricle and right ventricle are thickened. The atria are very dilated, and there's some thickening in their interatrial septum, and even the valves are thickened. And this is classic for cardiac amyloidosis. And this patient had wall thickness of 1.7 to 1.6 centimeters of the walls. Normal is only 1 centimeter, so very thickened. And this is the EKG showing that there's no LVH by EKG. On the flip side, 78-year-old African-American female with a history of high blood pressure, ejection fraction 45%. I'm sorry, I have to go back and tell you that this was AL amyloidosis, as you would expect from the nephrotic syndrome. This is 78-year-old African-American female referred for shortness of breath. Here you can see the EKG. And again, her echo is suspicious, showing biventricular thickening, biatrial dilatation, and some thickening of the valves. And in her case, she had a workup, and she had ATTR, and she had the hereditary due to the V122I variant. So those are two very different conditions. They're treated very differently. They have different prognoses, And in the case of this hereditary case, the children need to be tested. So I'm just going to finish with a one more TTR case. It's an 81-year-old white male who has a history of bilateral carpal tunnel syndrome years ago, spinal stenosis, and even a biceps tendon rupture. He was diagnosed with diastolic heart failure and AFib, and these are his medications. Here's his electrocardiogram showing actually LVH or LV hypertrophy on EKG, but the wall thickness was 1.6 centimeters in the septum and the lateral wall or posterior wall, which seems to be out of proportion to hypertension. And here you can see the apical four-chamber view again showing biventricular thickening, very big atria, and there was significant suspicion. And so this particular patient was worked up and was diagnosed with the wild-type version of TTR cardiac amyloidosis. So in summary, ATTR and AL cardiac amyloidosis are two different conditions with two different prognoses and very different treatments. Thank you for your attention.
Dr. Hanna's message is clear. Cardiac amyloidosis by itself is not enough of a diagnosis. Clinicians must go further to identify the type of amyloidosis and possibly even the subtype before any treatment may begin to be planned. I hope you enjoyed today's episode. If you'd like to watch Dr. Hanna's video, please visit Mackenzie's Mission Education Hub at mm713.org. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.